Good morning, all, and thank you for joining us for webinar 4 of the Swim Towards Stewardship program. Today, we've got Dr. Castignini joining us to present on optimal antimicrobial prescribing. As we get started with today, we want to give you a few instructions if you're new to Zoom. Zoom is a webinar platform, and it's got just a few user functions we'd like you to know about. In the bottom middle of your toolbar, you'll see a few, 3 functions in the middle. Furthest to the left is the chat function. Please utilize the chat function to interact with Dr. Castignini and the rest of our project team, and certainly the hospitals in our fishbowl throughout today's presentation. If you have a question and you'd like us to call on you, feel free to use the raise your hand function. Or if you have a specific question you'd like to submit, use the Q&A box to go ahead and type in a question, and we'll either chat back to your response or answer that throughout the course of today's presentation. A couple of additional instructions before we launch into content today. For members of the Compass HIIN, I want you to know that this session will be recorded and will be transcribed. In the coming days, we'll be providing you a link where you can access this presentation, the slide deck, and the recording, and also give you the direct link as well as those that link directly to the Innovation Resource Library, so you can share that with members of your team who may have missed the live event today. Before I introduce Dr. Castignini, I'd like to welcome you all to this Fishbowl series and give a special welcome to our 4 hospitals who are participating actively in this Fishbowl. They've signed letters of commitment. They've got leadership buy-in. These are 4 teams led by their institutional pharmacists, and they have been engaged and actively participating in monthly coaching calls with our subject matter expert team, trying to move forward with different aspects of stewardship and certainly the core elements. So I'd like to welcome them all today and thank them for joining. Without further ado, today it is my great pleasure to present to our speaker, Dr. Castignini. He is the assistant professor in the Department of Pediatrics at Baylor College of Medicine and the Children's Hospital of San Antonio. Dr. Castignini received his medical degree in Lima, Peru. He went on to perform his residency in general pediatrics at Miami Children's Hospital in Florida. His fellowship in pediatric infectious diseases at the Baylor College of Medicine. He obtained a master's degree in public health from the University of Texas in 2010, and he currently serves as the director of Antimicrobial Stewardship program at the Children's Hospital of San Antonio. Dr. Castignini is a board-certified pediatrician and pediatric infectious disease doc by the American Board of Pediatrics. Dr. Castignini, the floor is yours. Thanks for joining us today.
Thank you very much, Kate, for the introduction. So we're going to discuss today about optimal antimicrobial prescribing, but before we start, I just want to mention one thing. I worked in Des Moines, Iowa for 4 years, so I know the state relatively well. I traveled around the state. I got to meet people and folks from the largest cities in Iowa, and I have a strong connection there. I have lots of friends, and I have Iowa in my heart. As I'm broadcasting this through the cyberspace, I'm sitting in my office at 54 degrees Fahrenheit in San Antonio on a rainy day. I don't know how the weather is today in Iowa. I heard you had some snow last week. That's probably one thing I don't miss a lot, but you know, everything is nice there as well in the fall. Let's go over first the outline of the presentation. We're going to talk a little bit about the background and definition, so we all speak the same language. We'll discuss a little bit about clinical decision support systems and how can your IT group help you in implementing antibiotic stewardship programs in your centers. We'll discuss pathways and guidelines, something I find extremely helpful and useful. It doesn't matter if you're very small or very large center, these pathways and guidelines are very, very helpful for providers, and it improves the care we provide. And I'll show you that throughout the presentation. We'll discuss about the antibiogram, what is it, how it's made, what elements to include, what elements maybe you shouldn't include. And of course, at any point, you can ask me questions about that. This is one of the most, I guess, controversial or difficult topics. And at the very end, I have a few slides on timely de-escalation of therapy and what the role of the laboratory and biomarkers is on this. So moving forward, I have as background, my favorite definition of antimicrobial stewardship, next slide please, is was published in 2001 by Dale Gurdon, and as you can see there, you can read it. Good antibiotic stewardship is a practice that ensures the optimal selection, dose, and duration of an antimicrobial therapy that leads to the best clinical outcome for the treatment or prevention of an infection while producing the fewest toxic effects and the lowest risk for subsequent resistance. And this is the fourth webinar. You've seen this many times. You're all on board with this definition, I'm sure. But I always put it on any presentation I gave related to stewardship because it's important to remember that this is all about quality of care. This is all about quality. This is all about the best care we can provide to our patients. As you can see there in the definition, there's a line that says best clinical outcome. And but unfortunately, go ahead, Kate, next slide. Unfortunately, these, as it was already described in 1945, this quote is from Sir Alexander Fleming in 1945. The microbes are educated to resist penicillin, and a host of penicillin-fast organisms is bred out. In such cases, the thoughtless person playing with penicillin is morally responsible for the death of the man who finally succumbs to infection with the penicillin-resistant organism. I hope this evil can be averted. So this is 1945, and you know, these warnings not to abuse antibiotics date that many decades back. So we need to find new systems and new ways to implement antibiotic stewardship. For example, the use of clinical decision support tools or new laboratory aids, as you will see during this presentation. This was published in 2006, The Common Pitfalls in the Use of Antimicrobials. And you know, you all know probably that up to 50% of all antibiotic prescriptions are either unnecessary or inappropriate. So there's a lot of work and a lot of improvement that can be made. Most of those are drug-bug mismatches. So we use broad-spectrum agents to treat susceptible bacteria, or we have sometimes the wrong dose or the wrong route. So it can be given either IV or oral, or that switch can be made. Or occasionally courses are longer than needed. And as you will see in the next few slides, I will describe some of those situations and how can we improve in those. Some other definitions, just so we are in the same page when we use these words: prophylaxis treatment, preemptive treatment, empiric therapy, definite therapy are words that we use all the time. And I will encourage everyone to be very familiar with when those words need to be used. One definition we're going to be using a lot during this presentation is the empiric part of it, because this is when the antibiogram plays a role, when pathways play a role, when clinical decision support systems play a role on how to select the best empiric drug. Most of the others are relatively, maybe is a little simpler, because once you have the organism and you have susceptibility patterns, to make that decision is a little more straightforward most of the time. Some examples of these interventions include prophylaxis, for example, endocarditis after dental procedures, or surgical site infections. Every patient that goes into a surgical suite that will have a surgical intervention that requires prophylaxis should get it. The data is very clear in preventing infections. So those are things that, for example, in my institution, we look at very closely in the antibiotic stewardship program. It looks at very closely with the infection control group. Preemptive therapy is defined as treatment for an infection that is not yet there, but it will happen if you don't give the treatment. So the organism is present, but it's not yet causing the infection you're trying to prevent. So it's kind of when you've detected that, for example, salmonella is in the stool of someone that may subsequently develop disease from it, you treat it. Or the examples that are listed there in the slide. Empiric therapy, which is the most important one in my mind, because it's the trickiest one, because we need to select something that is narrow spectrum and it will be safe for the patient, and we'll also treat the infection effectively. So, for example, sepsis or community-acquired pneumonia are examples of that. The patient shows up in sepsis or with a classical clinical presentation for pneumonia. What antibiotic should I use? And that is, by definition, the empiric situation. The definite use of antibiotics is when you have an organism, which is not always possible, but an example for that is bacteremia, and you get a blood culture that's positive for MRSA. That decision is made right away and on the spot. So those are some examples of the use of antibiotics. Like I said, empiric therapy is what we're going to talk more about today, empiric therapy and optimal prescribing. We have to think about what is the likely pathogen. And here, the antibiogram and pathways play an important role. You will not use the same antibiotic for a patient that comes in with cellulitis than a patient that comes with a urinary tract infection, because the likely pathogen in both processes is different. So providers can be helped with the presence of an antibiogram in your institution, or a guideline or a pathway for those two conditions. The same applies for respiratory infections, pneumonias, musculoskeletal infections, and so forth. The site of infection is also very important to remember for the same reasons I just mentioned. The safety of the drug. So there's host and drug factors there that need to be included in the decision-making process. Safety, if the person is allergic to it or will develop a side effect from it, you're better not using that drug. So those can be included in guidelines, pathways, etc. And last but not least, treat infection, not colonization. And this happens all the time everywhere. I'm sure you see it in your institutions that a culture is obtained from a non-sterile site, say, for example, an ET tube on a patient on a ventilator, or a screening test looking at the nares, looking for colonization with MRSA, and sometimes providers are tempted to treat it. Antibiotic stewardship programs have a significant impact on not treating this and treating just the infection. Of course, there's always the difficulty to separate the two in some patients, and we'll talk about how that can be averted. I included this slide here because I wanted to show you what some are simple and some not so simple pharmacy-driven interventions. So if the patient can tolerate the oral route, is on full diet, and has an infection that can be effectively treated with a very good bioavailable drug, for example, clindamycin has 100% bioavailability through the gut, and you have a cellulitis or that's getting better, then pharmacy can drive this intervention and change the IV form to an oral route. Then dose adjustments. The next one is dose adjustments in cases of organ dysfunction. For example, patients that have renal dysfunction, and you need to adjust the doses. That can be done by pharmacy. The same with dose optimization. Sometimes the dose that's recommended for an infection is different than the dose that's recommended for a different infection, and pharmacy can act on that, call and give feedback to the providers, or if you have that in your institution, can make the change automatically. Automatic alerts in situations where the medication may be duplicate, for example, is another one. That if you're using two drugs that have anaerobic coverage, say Sozin and Flagyl, you can put those two in an alert that when it happens, you can call back and say you don't need those two drugs, you can stop one or the other. And of course, discussions always are important with your primary team and making sure that your providers are on board with what you're recommending. Antibiotic-related drug-drug interactions is another one that I always bring up in this type of situation, pharmacy-driven interventions. So let's move on and talk about the clinical decision support systems. Clinical decision support systems are a very, very valuable tool. They are expensive, some of them, and sometimes centers are reluctant to implement this in their centers because of the cost. But I hope I can show you that these are very cost-effective. And in less than a year, some studies have shown that you can recover all the investments on these systems. So what are these? The clinical decision support systems are computer softwares or programs that are designed to generate some type of value in the diagnostic or treatment processes. It gives recommendations. It does not change any of the therapies. It does not change. Of course, it will not override the provider's or the pharmacist preferences, but it will give recommendations. It can be used for multiple types of medications, and of course, our topic, antibiotics, but it has been used for anticoagulation. It has been used for chemotherapy. There are studies looking at multiple lines of treatments or medications that these can be used for. So in case you need to sell these to your administration, in case you don't have one yet, don't just put all your mind in antibiotics. It can be used for other clinical areas as well. Patient-specific data are used to provide one or more recommendations generally related to diagnostic testing or treatment alternatives. And it has been shown, as in that study published in the Journal of the American Medical Association, as I'm going to show you in a few slides, to have all those impacts: decrease in errors, decreased use of antibiotics, decreased length of stay, decreased cost, decreased side effects, improved surveillance. All these processes, or everything we're doing can be tracked with these clinical decision support systems. In this study, for example, click one more time, Kate, please. As you can see there on the right, all the values that were measured in this study was done in critical care patients in an intensive care unit with 12 beds. So this was done on a medium-sized critical care unit. 12 beds is a reasonable, probably even a large size by some standards. They looked at more than 2,000 patients, and they compared the pre-intervention period before the clinical decision support system was implemented, and they compared to after. And you can see all the variables that they looked at. They looked at the number of different anti-infective agents that were ordered, duration. They looked at the number. They looked at days of excess of anti-infective drugs, the cost, length of stay in intensive care units, etc. At the bottom there, you have total cost of hospitalization. As you can see, every single measurement was significant. And if you can look at the p-value there, is extremely significant. Let's focus on one that says total cost of hospitalization. Before the intervention was made, the total cost of this unit was $35,000, and after the intervention was $26,000. And this is just to show you when the physician followed the intervention that was recommended by the program. Because as I said before, some providers may overwrite what the computer is recommending, and if they did, as you can see there, the cost went even higher than the pre-intervention period, which is interesting. The next one, please. These clinical decision support systems have also shown that it's very effective in the outpatient setting. So the previous slide showed the critical care side of the component, critical care side of things. This is looking at clinical decision support systems in the outpatient setting. This is a study I was quoting before. It was published in 2005 by the Journal of the American Medical Association. It was done in Utah and Idaho in 12 rural communities, very small hospitals, and it was done in ambulatory settings. So this was all outpatient, and it was only done for acute respiratory tract infections. And as you can see there on the graph, in graph A, the lines represent the clinical decision support system plus an education intervention. CI alone means the community intervention alone, which is just education. And there was a control group. And as you can see, in 2002 compared to 2003, there was a significant decline in the total antimicrobial prescription. And in the graph B, you can see the macrolide prescriptions, you know, azithromycin, which is something that we use all the time in emergency rooms. Sometimes I feel like azithromycin is placed on a candy ball at the entrance of the ER. People always go out with some in their pocket. And these can be significantly decreased, as you can see by the implementation just of a clinical decision support system in addition to the education. So some examples of antibiotic support systems related to stewardship, to antibiotic stewardship, are listed here. Some of them are part of larger enterprises, and they have these systems that will integrate with your pharmacy. I do not have any commercial relationship with any of these. I have to mention, however, that we use in our hospital, we use the third one, Theradoc, and our hospital is part of a larger corporation and a larger system, and there are many, many hospitals associated with that corporation, and they got this clinical decision support system for all hospitals. So we are able to use it, and we can tailor it to just our own institution if we want. Because, as you know, I'm a pediatrician, and I work at a children's hospital. So we tailored it for our institution for children. Other centers are using this in their own setting for adults or critical care, etc. These systems can integrate easily with your EMRs or with your pharmacy software, so it can track medication utilization, it can give you alerts, it can give you clinical intervention tracking. So we track our interventions using this system. So it helps a lot because it saves resources. We don't need someone that does this manually, which will be very labor intensive. And it can track prices, it can detect cost savings, and etc. Interventions of all kinds. These can also integrate with infection control, and so you can track, you know, infection control interventions or isolation precautions, or what's the rate of patients getting into intrahospital infections. As I mentioned before, these are some of the examples of the alerts and functionality that these programs have. You can see it there in the list. Positive cultures will be immediately alerted. Targeted drugs, you can put the drugs you want on that list. We have, for example, carbapenems, linezolid, voriconazole, daptomycin listed there. So if anyone prescribes that in our institution, I will get an email, so I can reach out and see why that's being prescribed, and see if there's an alternative drug that can be used. If there's duplication of therapy, or you're looking for a specific organism like Pseudomonas or a multi-drug resistant Acinetobacter, it can be flagged and you can be notified of those. Timeouts, duration of antibiotics are very important, are very helpful. These can track that and help you implement those. If you want to use, for example, a 3-day vancomycin rule, that is, if the provider orders vancomycin, at the day 3, there will be a flag that will tell that provider, or it will tell you in the pharmacy or anyone that's running the program that maybe it's now time to reconsider that choice, or not, or continue using it. It's just a way of alerting you. Moving on, let's just talk now about pathways and guidelines as the tool for better prescribing. As I mentioned at the beginning in the introduction, these can be extremely helpful, and it's relatively easy to do. The commonly used pathways include community-acquired pneumonia, for example. There are guidelines from Infectious Disease Society of America and other entities that will tell you, if you need a blood culture, if you need to admit the patient, or if the patient requires oxygen, what to do, if the patient requires ICU admission, and that can all be placed in one page to help the provider. The provider does not necessarily need to follow it, but it can be helpful. And even the most reluctant providers look at this, and they start little by little changing their practice. And as I'm going to show you in the next few slides, you will see that there are studies looking at the prescribers or the providers' attitudes in front of these pathways, and there's change that can be implemented. As you can see there in the list, you can do these for urinary tract infections and others. I wanted to include, go ahead, Kate. I wanted to include the Texas Children's Hospital, which is affiliated with my institution. This is a copy, just a screenshot of their webpage. So this is available to everyone that has access to the internet. And many institutions have these open for everyone to use. So I will encourage you that most of the work is done. If you go to, for example, I use this because I'm familiar with this webpage and this institution, but and this is just for children, but there are other institutions that have these for adults and for different clinical entities. In the next slide, you will see all the ones they have for Texas Children's Hospital. They have all these, as you see on the left, all those are related to infection. And if you click on the link, it will take you to a pathway that's probably 6 to 7 page long on average, because it includes all the rationale behind it, and includes all the references you need to know about it, and includes all the people that intervened, on all the people and dates on when they met. So all that is probably not very practical to have handy, but at the very end of the document, you will have a pathway itself, an algorithm. As you can see in the next slide, I just used one that's the Texas Children's Hospital, that's TCH, Evidence-Based Outcome Center Clinical Algorithm for Skin and Soft Tissue Infection. And you see there at the very top the date, and this is just half of it. The other half will be in the next slide, but you see how it's done, and you can see, you can follow it. I'm not going to go over it now. I just wanted to show it to you so you see how it looks, and it can be replicated and tailored for your own institution. If there's something here that you find that it's unpractical or not, does not apply to what you are doing, then you can change that. As you can see there, you have boxes on the side for comments. You have inclusion criteria, exclusion criteria, septic shock criteria, so you can go off the algorithm if that needs to happen. On the next slide, I have a study, and this is for adults. And in this is a retrospective pre-intervention and post-intervention comparison, where they used decreased antibiotic utilization after implementation of a guideline. So this is just looking at what happens if I apply a guideline for inpatient cellulitis and cutaneous abscess. And I look at what will be the impact of implementing this simple intervention before and after. So they looked at 1 year pre-intervention in 2007 and 1 year post-intervention from July 2009 to July 2010. And what they did was just they recommended one drug for cellulitis and cutaneous abscess. In this case, they used vancomycin. A total of 7 days of antibiotic therapy was recommended. And with conversion to a generic oral step-down therapy, if the patient has improved. So with that basic steps, they were able to make substantial differences. There were no increase in treatment failure rates, despite using a narrower spectrum antibiotic, because before they were using 2 drugs and one was covering gram-negative organisms. And the conclusion of the authors is there in the slide. Implementation of a guideline in the management of cellulitis and abscess led to shorter duration of more targeted antibiotics therapy and decreased the use of resources without affecting the outcomes, which is very important. Occasionally I hear from physicians thinking that this guideline removes the freedom for them to choose what antibiotic they want to use, which is incorrect because this is just a guideline. And if they apply the guideline, they are concerned that their outcomes will not be as good as they are currently. And so these studies are very, very helpful. There are plenty of these studies in the literature. That study was inpatient, and this one right here is for outpatient management. So it can be applied for both inpatient and outpatient settings. Here you can see the effects of clinical pathways for common outpatient infections on antibiotic prescribing. They looked at 8 primary care clinics, and they randomized these clinics to receive the pathway for things like acute bronchitis, rhinosinusitis, pharyngitis, otitis media, urinary tract infections, skin infections. Treatment of pneumonia as an outpatient was in there as well. And they provided education materials and the pathway to one group of clinics, and then they randomized another group, which was the control group with no intervention. And they assessed the trends. And you can see in the next slide, this is just an example. If you go to this paper, you will find all these algorithms there. So this is accessible and it can be replicated by your centers and institutions. You see there, this is just for acute rhinosinusitis in non-pregnant adults. And you see that box there for inclusion criteria and some general concepts about the disease and how you can track down and see what antibiotic can you use in one setting versus the other. It's very helpful, and I will strongly encourage you to look at it. In the next slide is just the general results. The study group is in the dotted line, and the control group is in the solid line. The intervention is there in May 2010. And as you can see, there was a significant decline of the total percent of prescribed antibiotics. In fact, they reduced the antibiotic prescription for 43% in the pre-intervention period to 37% in the post-intervention period, which was an 11.2 relative reduction with statistical significance. The arrows in your slide are a little off place. The arrows should be after the intervention there, just to show how much the decline happened. So moving on, the antibiogram. Let's talk about the antibiogram and try to make it a little bit a complicated process and a complicated problem a little simpler. So what is the antibiogram? The antibiogram is defined as a profile of local susceptibility to antibiotics for each bacterial isolate to a group of commonly used antibiotics or antimicrobials. And it serves primarily 2 purposes. The first one is helping the provider, the clinician or the pharmacist, to select something empiric. You don't know yet what's causing the problem. You don't know yet what organism you're dealing with. But if you know what condition you're dealing with and you look at your antibiogram and try to find the most common organisms for that condition, you will be guided into what is the best therapy. And the second purpose is surveillance. And this is as important, or maybe even more important, because you can track over time what's happening with the organisms in your community. You can track what's happening with Staphylococcus aureus. You can track what's happening with multi-drug-resistant gram-negative bacteria. Are we getting a lot more resistance over the years? Are we seeing a decline in the resistance? It can also depict the impact of your stewardship program. Studies show that stewardship programs have impacted the resistance, in that there's a decline in the emergence of resistance. So these can also help moving forward for more resources and getting your leadership on board as well. So how to generate an antibiogram, and this is very tricky. And this is here in the slide you see a guideline on how to present and how to make an antibiogram. I will encourage everyone to look at this document, because there's a nice table there that you can follow and it will help you implementing an antibiogram for your institution. This was published in 2007, and it was as part of the clinical laboratory institutions standards that guides antimicrobial susceptibility. In the next slide, you will see some of the summary of what is needed to generate an antibiogram. First, it should be done at least annually. It should include at least 30 isolates to guarantee statistical validity. And I'm going to go one by one in a further slide. For Staph aureus, calculate separate cumulative antibiograms for all isolates and a subset for MRSA. Include only diagnostic isolates, which excludes all screening isolates. Include only the first isolate of a given species per patient per analysis period, and we'll talk a little bit about that. Report results only for antibiotics that are routinely tested. You wouldn't report nitrofurantoin for a bacteria that's isolated in blood because that's only used for urinary tract infections, for example. And you should generate separate reports for each healthcare facility served by your laboratory. So sometimes there are centralized laboratories that you'll send your isolates to. Don't put all those in the same basket for reasons I'll explain in a minute. And last but not least, and this is where people have a lot of problems, is should I include long-term care facilities? So should I include patients that come to clinics, patients that were seen in the ER but never admitted? Outpatients versus inpatient? Should I include patients that acquired the infection in the hospital, so an intra-hospital acquired infection? Should I include cystic fibrosis patients? That's for pediatrics, for example. We have a cystic fibrosis center here, and they have very multi-drug resistant organisms. Should we include those? So we'll try to address some of those concerns in the next few slides. So for example, the frequency that these should be reported. The guidelines suggest that at least it should be done once a year. Some other institutions do not have enough isolates or do not have the manpower or the support to do it every year. It's fine. Every 2 years is better than nothing, in my opinion. I think it will help you track. I think it will help you look back in a decade's time. You can look at what was happening in 2018. You can look at has E. coli become more resistant, and maybe you will look at that and say, no, it's actually not true that E. coli has not become more resistant to, say, third-generation cephalosporin. And as you have that data in my mind are, if it's well obtained, is factual, are facts. So in 10 years from now, if a provider wants to use a drug that you consider to be too broad for that infection, you can say, well, in 10 years that we've been tracking this data, we have not seen any increase in resistance. So it's persuasive for providers and clinicians and pharmacists alike. The number of isolates, 30 is what the guideline recommends. This is very tricky because it's very difficult to get 30 isolates, very, very difficult to get 30 isolates in 1 year period in small hospitals. For example, my institution is probably medium-sized compared to other children's hospitals, and we do not get 30 isolates of Streptococcus pneumoniae every year. And that's a very important organism to report. The same with Acinetobacter. We want to track resistant patterns. We want to track resistant patterns of Serratia, and we do not have 30 isolates. So we've decided, and this is a decision that every institution can do on their own, we've decided to report that, even if we don't reach the 30 isolates, because we think it's valuable information. While it will not reach statistical significance or statistical validity, it's still useful for the provider to see, well, 100% of all Serratia has been susceptible. That tells you something, even if you have 10 isolates, right? The guidelines suggest that if you can combine data from other facilities that are in the same geographical location, the same area where you have your hospital, then that might be feasible or acceptable. I don't know if you do have that possibility. Screening culture should not be included. A lot of institutions are now screening patients that go into ICUs, go into the operating rooms to see if they're colonized with MRSA or other organisms, VRE, vancomycin-resistant enterococci, for example. You should not include those in your final antibiogram report. The data should be presented as a percentage of isolates that are susceptible, not the other way around. You do not report resistance, you report susceptibility. What to do with repeat isolates, and that's one key aspect. So let's say a patient comes in and gets a blood culture that has MRSA in blood. But then on day 3 develops a decubitus ulcer that gets infected. And you get a culture from that, and you get another MRSA that has a slightly different susceptibility pattern. Do you report that? Do you include that in the antibiogram? For practical purposes, the answer is no. The guideline recommends to just report the first isolate of that species. So if you get one isolate for Staphylococcus aureus, you should report just that, even if the susceptibility patterns on subsequent cultures from different sites grow Staphylococcus aureus. I hope that's clear, or if you have any questions, of course, I can answer at any time. Next slide, please. This group of investigators looked at what happens if you don't follow the guideline in terms of what I just mentioned. What happens if I include in the first graph there on the left of the slide, they looked at, okay, let's include all screening isolates and see if we can get useful information from it. And the answer, in short, is no. Because the resistance increased significantly, and it was not depicting what the diagnostic isolates were doing. So in general, in summary, you should only include diagnostic isolates. On the right side of the slide, you see multiple different approaches to repeat isolates. Say you get multiple isolates, and you have there in the darker is all isolates. The next one is 2-day episodes, so it's 2 days later, there's an episode of an infection, and thousands of patients were included in this analysis. And as you can see, the resistance starts decreasing over time for those organisms tested. So you're reflecting something that is not what brought the patient to the hospital. So overall, the summary on this slide and the previous one is that you should include just the first isolate, and that's actually mentioned in the guideline. In the next slide, I included our own antibiogram. This is children's, inpatient only, and these are the organisms we are reporting. We decided to do it this way. We find that it's helpful. We tweak it every year with new information or some opinion from some provider that says, well, this is confusing. I don't understand what you mean by this. We change it. So for example, there at the bottom where you see gram-positives, you have MSSA and MRSA in as different organisms. Other antibiograms will say Staphylococcus aureus as a single one, and then report in the antibiotics what percentage is susceptible to oxazolin, so you can infer the MRSA rates. In the next slide, it's an adult hospital from our corporation as well. And as you can see, not all the isolates listed there reach 30, but they are found to be valuable to the providers. The Stenotrophomonas maltophilia there at the bottom of the gram-negative list is valuable, because we want to track down, and you can add that to other years and kind of look at the antibiogram from 10 years ago and look at, is Stenotrophomonas getting more resistant to quinolones? We can look at that, and kind of that it will drive change. It will drive modifications. In the gram-positive ones here, as you can see, Staph aureus is listed there as a one organism, 206 isolates, but there at the bottom as a footnote, you have the MRSA percentage. So different institutions presented their data differently, and I think I would encourage you to do what works for your institution. You can, of course, this is for you to keep as a guide, and you can use any of the information I'm presenting here as well. Some limitations of the antibiogram: minimum inhibitory concentrations are not included, are not depicted. So you can see there when you have MIC creep, what that means is that an organism that's still susceptible, but the concentration of antibiotic needed to kill it is going up over the years. That's called the MIC creep. So a Pseudomonas that is susceptible to Piperacillin tazobactam now, and it's susceptible 10 years later, both are susceptible, but the amount of antibiotic needed to kill that bacteria was higher in the 2 time periods. That is not depicted in the antibiogram, so that's one limitation. The other limitation is that you do not include patient factors such as medical history of past exposure to antibiotics. That does not go in the antibiogram. The other thing that is not included is when you have cross-resistance of organisms. For example, not long ago, we wanted to know how many of our Pseudomonas that are resistant to aminoglycosides are also resistant to fluoroquinolones. You cannot get that information from the antibiogram, and that will be very helpful. Synergy, some physicians like, or some providers like, look at synergy. For example, listeria, a response to a synergistic combination of ampicillin and gentamicin. That's not depicted on the antibiogram either. And again, this data is for a local hospital only. It's just for your institution, and it's not general. It cannot be generalized. So that's for antibiogram. And I have a few more slides on de-escalation of therapy, which is the biggest question. When to stop that antibiotic, when to de-escalate from a broad spectrum antibiotic to a narrow spectrum antibiotic. And that decision is done at the bedside, but you all have a good impact on how that can be made and how can that be made effectively without compromising care and getting the best you can from a resource standpoint. So there's been a lot that has been studied on the escalation of therapy and how can that be done the best way possible. And one thing is biomarkers. And biomarkers are biological substances that can be measured and can be objectively and reproducibly measured. You can measure, if you measure procalcitonin or CRP on a patient right now twice, the value is extremely similar between the two measurements. So accuracy is important and reproducibility as well. So it can be an indicator for physiological and pathological process. So the commercial available biomarkers, CRP and procalcitonin. Procalcitonin is a pre-hormone of calcitonin, and it's believed to be secreted by the liver in response to an inflammatory reaction or to inflammation in the body. And it correlates a lot, it correlates very well with inflammation caused by infection. And mostly, and very importantly, that infection caused by bacteria as opposed to viruses. So it's very helpful, this marker is very helpful in knowing which patients may or may not be infected with a bacteria and when to de-escalate therapy. Other biomarkers listed there are not commercially available but are under research, and I thought I'll mention them. And the advantages of this is fast for the most part. If you have that in your own institution, if you have the machine that can be run in your lab, it will be low cost and you'll have results in a couple of hours, and you can make decisions at the bedside right then. It's very helpful. There are multiple studies. There's a lot of studies looking at CRP and procalcitonin performance and how well they can predict or tell you information that the patient is infected with a bacteria. I'm just showing you one that it's a meta-analysis. This is a systematic review looking at multiple studies at the comparison of CRP and procalcitonin. This graph is called the receiver operating graph. Dots that are at the closest left upper corner of the graph are the best. So, and that's each individual study looking at procalcitonin, and this curve where you see PCT, that curve is showing you how well this is performing. In summary, procalcitonin is very accurate in detecting bacterial infection. And most importantly, it has a very, very high negative predictive value. That is, a negative procalcitonin in higher than 95% of the time is telling you that the patient does not have a bacterial infection. The other way around does not work, unfortunately, as good. So that is, if a patient has a positive procalcitonin, that does not necessarily mean that the patient has a bacterial infection. Those numbers are better than CRP. Procalcitonin is a relatively fast and low cost if you have that availability in your institutions. So the few last slides. Considerations for de-escalation of therapy. You should reassess antimicrobial regimens daily, on a daily basis at the bedside. Do we need this antibiotic? Should we continue this antibiotic? And you will look at clinical response, and I apologize for the typo there. That's reevaluate based on clinical response and microbiological data. What if you have a culture negative patient, patients with pneumonia? Very uncommonly, they'll have a blood culture that's positive. Patients with osteomyelitis that did not require a surgical intervention may not have a positive culture. Well, you started something empiric, and you can de-escalate as the patient gets better and your inflammatory markers and biomarkers go down. The IV to oral switch happens a lot in pediatrics. I know in adult medicine, it's still not being done as commonly, but you know, data is coming out more and more to suggest that once the patient's better, you should de-escalate going to the oral route. I always encourage everyone, the learners, residents, medical students, other physicians, other providers, nurses, to plan duration of therapy at the time we start. The day you start antibiotics, you should have at least an idea on what you're going to do in the next few days. If you just start antibiotics because the patient's sick and you just want to throw antibiotics at them, in a few days you're going to find yourself not knowing what to do, and that is something that I discourage and I always mention as I round in my clinical service. Biomarkers, again, are very important. So just in conclusion, briefly, I would say that optimal prescribing is a team effort. You need to include everyone in your team, providers, pharmacists, nurses. Clinical decision support systems are extremely valuable and a very cost-effective tool. And you should work on an antibiogram. One intervention at a time is more valuable than multiple interventions all at once. And I say that because you can get your pathways one at a time rolled out. And as physicians start seeing that and getting used to seeing that the hospital or the institution as a whole is working towards that, you will start driving change. And always measure what your interventions are, measure what you're doing. Antibiogram, again, is very important. Even if you have a small institution, a small hospital that will not reach those 30 isolates that the guidelines suggest, keep track of what these isolates are doing over time. You will find that that's very helpful in the future. And of course, I always say this at the very end, education is key to a successful antibiotic stewardship program. So always talk to your providers about this and to everyone around in your center. And I will open now for questions. Thank you very much.
Thank you so much, Dr. Castagnini. This is Kate Carpenter back on the line. And at this point, we'd like to turn to our fishbowl hospitals and ask for certainly any pressing questions that you have while we have Dr. Castagnini with us today. We'd like to answer those, or any just thoughts or reflections you have on today's content and how you might move forward in the next month of project work. I'm going to open the lines now. If you'd like to comment, please unmute your line. Dan LaGrange, can we turn to you guys? Are you on the line with us? Any thoughts from today's webinar?
Yeah, we're here. Nothing in particular. We'd kind of been working through our antibiogram in last month's meeting, and Dr. Castagnini is our advisor, so we were able to meet with him and got a lot of these questions answered.
Excellent. Jill, are you on the line?
Yes.
Any questions that you all have?
No, not really at this time. So our lab is going to work on getting some data for us. So
That's great. Do you guys have any clinical pathways currently in place at your facility, Jill?
no, not specific.
Okay, do you mind if I jump in real quick?
Yeah, go ahead.
Are there any of the hospitals? Do you have clinical decision support systems in place. Is that something that that you have integrated in your EMRs or any type of software that's helping you with these tasks?
We do, but not for antibiotics. And it's not software.
This is Jeff at Mercy. We have Theradoc at our facilities. I would concur with Dr. Castanini's comments that it is very helpful and does streamline our day-to-day activities. In addition to being able to, we use it to track interventions and provide reports to administration. And we don't just use it for antimicrobial stewardship, we use it for other pharmacy-related monitoring, such as we have all sorts of alerts built for high-risk medications and interactions and things like that. And we also use it as kind of a rounding tool for our pharmacists who are providing multidisciplinary rounds in various units throughout the hospital. So it is very useful. It is expensive, but activity-wise, it's helped a ton.
Sarah, are you on the line? I want to give you a chance to chime in with any thoughts or questions you might have.
Thanks, Kate. Yes, I am here. I think Dr. Castanini did a great job of going over a lot of these tools that can be utilized in your hospital. I do agree that having some sort of software that you can really help manage some of this is extremely helpful, and it really allows you to dig a little bit deeper into what your antimicrobial use is. But otherwise, I think that the presentation was great, and there's a lot of really good resources and information shared today.
Thank you very much, Sarah. Anybody else on the line that'd like to get a question or a comment in as we close today? I'm going to take a brief pause. Well, in closing, I just want to remind you of some of the next steps kind of as we move in to the 5th month of work. I'll encourage you all, team leads, please do email your assigned coach this week or beginning of next with your availability. Sometimes you might have that you could meet virtually with them this month. Keep going. We challenge you to continue taking action each and every month. And we were just talking prior to this webinar, you all have done so much already in these first 3 or 4 months and taking some steps to meeting different core elements. So we want to encourage you and please use us. We have a project team, as you know, available to help answer your questions as we move through the project. Also, make sure your team's registered for Webinar 5, which is Pharmacy-Driven Stewardship. That's scheduled for November 14th. With the holidays approaching, we want to make sure we're being proactive and getting that on everyone's calendars. And then contact myself with the Swim Towards Stewardship project if you have any project-related questions or concerns, and I'd be happy to connect you to an appropriate resource. I want to thank you all for your commitment to antibiotic and antimicrobial stewardship and for your participation in today's webinar. Special thanks to Dr. Castagnini for presenting today's content. Thanks all and have a great week.
Thank you.